Implant illness is another chronic inflammatory process of which, in this case, a breast implant is playing a role. It's not the only thing playing a role. So that's why I don't ever tell people that explant alone is going to solve any problems because we're a collection of experiences over time and exposures and limitations in detoxification and how we live and all the things we do, right? So, I mean, it would be simplistic to just say, if we just do this surgery, everybody's going to be fine. If we, if it was that easy, I wish it was that easy. It's just, it hasn't worked out.
Hi, and welcome to the Lyme Bites podcast, where we shine a light on the misunderstood science of Lyme and other vector-borne diseases, as well as the truths that many still miss. I'm Dr. Mariah Hinchy, naturopathic physician and fellow of the Medical Academy of Pediatric Special Needs. I specialize in treating chronic Lyme disease as well as other complex inflammatory conditions. In this podcast, we break down what's working and what's not. We share the facts that most people miss, we challenge outdated thinking, and we give both patients and practitioners the tools to heal smarter. So let's get into it and change the way we heal Lyme. Hi, and welcome to another episode. I'm your host, Dr. Mariah Hinchy, and today we're going to be talking about breast implant illness. So in complex chronic illness, particularly Lyme disease, mold illness, and other infection-driven conditions, patients often remain stuck in cycles of inflammation despite targeted therapies. One commonly overlooked driver is the presence of implanted foreign materials, which can perpetuate immune activation, biofilm formation, and toxic burden. Dr. Robert Whitfield is a board-certified plastic surgeon and founder of the SHARP method, a biologic recovery system integrating surgery, genomics, detoxification, mitochondrial optimization, and regenerative medicine. He is nationally recognized for his work in breast implant illness and has published the largest series of PCR-tested explant capsules demonstrating bacterial contamination in nearly 29% of cases. With thousands of explant surgeries performed, he is also a pioneer in combining explant surgery with fat transfer to restore natural form without synthetic materials. Dr. Rob, thank you so much for joining us.
Thanks for having me on. I appreciate it. I feel like the Lyme, the parasite, the mold, the EBV reactivation, all the things end up troubling my patients quite a bit.
So what do you think are the biggest ways that breast implants can contribute to the overall chronic illness picture with systemic inflammation?
Well, I think if we, just generalize that any device causes inflammation, that's not, native to your body. So our body, from the T cell response is always going to recognize what's foreign or what's not self. And so I used to do breast reconstruction. And before I knew anything about there really wasn't breast implant illness probably in 1996 or to the early 2000s in that kind of nomenclature or terminology. I always thought that obviously any hip, knee, breast, dental, cardiac, neurologic, whatever device that somebody had to put in to help a patient with that wasn't their own tissue could get infected. We all knew that. And then there were studies done on particular blood vessel grafts. So things that would replace a blood vessel. They were tubular grafts and they would become infected. And it was very hard to determine what was causing the infection. And the concept of biofilm was talked about a lot. And it actually took a study where they vibrated the vascular graft, and that was able to release the bacteria off the surface of the graft so that they could figure out that it was something like staph epidermidis, which is a common bacteria associated with biofilm. Original biofilm is like plaque on your teeth. But so knowing that, I was taking care of patients with breast cancer reconstructions with implants that had been referred to me because they were having problems with firmness, hardness, which is a capture contracture. And one patient in particular, she came to me, it would have been like 2006, and she had redness of her chest intermittently and had pain and some tightness and sometimes difficulty catching her breath. And she said, is there anything you know, available now that you can do for me. And back then, I was one of the early people providing what's called DIP free flap reconstruction in the country. I had trained from 96 to '02 and '02 to '04. And I was now in practice after my microsurgery fellowship in '04 or '05. And I really wanted to do this type of surgery. So I traveled to Europe and Asia because we weren't necessarily doing a lot of it in the United States at that time. And I really pushed and pushed and pushed to start doing that surgery. And it's basically a technique where you preserve the muscles and the nerves and just take the associated blood vessel with the skin and fat of the lower abdomen that's discarded in the tummy tuck to make a breast reconstruction. You hook up the blood vessels underneath the sternum like you would use in heart surgery. So I did this for this patient, and this redness, this tightness, all that stuff went away because the tightness and the limitation on breathing is more a restriction of the expansion of the ribs, and the weight of the device is something that once you remove it is like doing a breast reduction. So there's multiple things happening, right? You're removing restriction of expansion from taking the scar tissue away so the chest can expand better. Then you're taking weight off the chest. Imagine having two Coke cans tied around your neck on a string. 330 cc's is a can of Coke. So put one on each side and tie it around a string, and that's kind of having a set of average size implants. Now, for reconstructive patients, because they've had mastectomies, those implants are always bigger normally. So if you do all those things and then you replace it with, think of your own tissue. So it's healthy, it's hooked up, it has a blood supply. That's the best of all, right? So now all the foreign material's gone, all the old scar tissue's gone. You can breathe easier. The weight is different because your own tissue is not as dense or heavy as saline or silicone, right? So that's a better natural form of reconstruction. Plus, it's always going to be smaller, not bigger. It can't be the same size. And I did that without knowing, what I was, doing essentially was removing this generator of inflammation. Now, some people don't deal with that as well as others, right? So there's genetic differences in detox capability and pathways. And then there's overall toxicity burden that we acquire through life. And in these patients, they were getting more and more treatments. So some of those treatments were platinum based treatments. Some of those treatments would be other chemotherapeutic agents. Then they would get potentially radiation. There's a lot of things that are getting thrown at those patients, in addition to where they grew up, where they worked, um, the food they ate, the air they breathed, the fluids they put into their bodies, the things they put on their skin. So all those things matter. And all those things affect how that person would, cope day to day. So I felt, obviously when I removed all that material and just did their reconstruction with their own tissue, that would solve this problem.
Right.
So when I, have patients come in and they have chronic inflammatory symptoms, I tell them all the same thing. Breast implant illness is another chronic inflammatory process of which, in this case, a breast implant is playing a role. It's not the only thing playing a role. So that's why I don't ever tell people that explant alone is going to solve any problems, because we're a collection of experiences over time and exposures and limitations in detoxification and how we live and all the things we do, right? So, I mean, it would be simplistic to just say, if we just do this surgery, everybody's going to be fine. If we, if it was that easy, I wish it was that easy. It's just, it hasn't worked out like that.
Right. So there's typically some other type of infection that is underlying and causing more maybe immune dysregulation, and that's why a particular person would be reacting to the implant versus somebody else. Are you ready to revolutionize your approach to diagnosing and healing complex chronic inflammatory illnesses in both adults and children? The Lyme Symposium is your gateway to cutting-edge education, groundbreaking research, and innovative therapeutic solutions. Join us at Lyme Symposium. at the Fort Lauderdale Marriott Pompano Beach Resort and Spa. Lyme Bites is the premier functional medicine conference on complex chronic infection-driven inflammatory illnesses. This year's meeting is jam-packed with leading industry experts discussing long COVID, mycotoxin illness, pandas, as well as Lyme and other vector-borne diseases. This conference will arm you with the knowledge, clinical pearls, and practical solutions that you can implement immediately into your practice Monday morning that will literally change your patients' lives and get them on their path to true healing. So join us at Pompano Beach or virtually from anywhere. Register now at lymebites.com. That's LYMEBYTES.com.
So we showed that in 694 consecutive explant specimen samples tested with PCR analysis that 29% have bacterial contamination. And
What
that's
type of
predominant
bacteria?
Staph epidermidis and Cutibacterium acnes.
Okay.
Yeah.
And have
So
you ever looked to see, or do you know if your patients also have like some sort of chronic infection, like Lyme or another vector-borne disease or chronic Epstein-Barr, or even like interactions with the spike protein from COVID?
So the way we look at it right now is with my program, we look at their genetics and we do a total toxicity burden test with Vibrant, and we do a gut test. We look at food sensitivities and we look at hormones and then basic blood labs. I haven't, because it's from a scope standpoint, when people are coming to me, they've already typically either been through the gauntlet or know
Mm,
they have Lyme or know something about a chronic disease process. Those folks are being taken care of differently. I do not get down with the workup for Lyme. I do have something that is a little bit frustrating for me, which is parasites.
yeah.
I feel like when I interview someone about Lyme, I can get some pretty straight answers most of the time. When I talk to somebody about parasites, I don't feel like I get any straight answers because I don't know that anybody has any.
Yeah.
So I rely on history. And so I just was seeing a patient before I hopped on this, and she's 9 months post explant, still has gut trouble, acne, doesn't feel well. That's code for I have a parasite. And so I just asked their travel history and I say, have you guys been down to Mexico recently? And they're like, yeah, we go all the time. I'm like, well, okay. So that's the problem, right? Their microbiome is different and can tolerate that. Ours is not, and we cannot, right? So you can't have Intimae histolytica, and you can't have hers, which is, oh gosh, fragilis, a diamantis fragilis or something. I mean, it has to be taken care of. And I don't know. It's not like I can't do it because obviously I understand, basic things, traveler's diarrhea, Intimae histolytica. But my use of some of these other antiparasitics is pretty limited in my practice, right? It's not really something that I've traditionally taking care of. I do handle a bunch of upfront antifungal therapy now with itraconazole and cholestyramine because I do a lot of simultaneous explants and fat transfers to help patients. And I want a patient who's got a pretty high mycotoxin level to have little to no mycotoxins if I can get them in a better position for that. And then, the number of patients who lived around agriculture, grew up around a golf course, were exposed to organophosphates is very high. So I'm constantly dealing with that now. And that's a big problem.
Yeah. So how do you determine if it is actually the implant versus one of these other, whether it's a toxicant, an infection, how do you determine what is the issue? What are
I don't
red
try.
flags that our listeners should be
I
looking
don't try
out
to
for?
determine that.
Oh, okay.
If
So
you've
so
come
your
to
feeling is if
Austin,
they're there and you have a complex chronic illness, they're a piece of the puzzle, they should come out.
well, pretty much the patients have self-selected, Dr. Henchy. So if you've
Okay.
shown up to Austin, Texas to have an explant surgery, you've already determined that that's your course.
Got
I
it.
don't ever tell anybody to explant. That's not my
Okay.
role. My
Okay.
role is to simply provide the educational information so you can make the best informed decision. That's
Okay.
a big decision for a woman to make, and I'm not making that for them.
Absolutely.
So,
So let me rephrase my question. For someone listening
yeah,
who has complex chronic illness
yeah,
and they've looked at all of the other things, they've looked at Lyme, vector-borne disease, mold, toxins, etc. They've addressed it, maybe
Mhm.
well, maybe not so well, but they're still
Yeah.
suffering and they have implants. Are there certain red flags that should suggest to someone, hey, maybe it's my implants that are the driving cause here?
Well, none of the biomarkers outside of the research biomarkers are commercially available to tell you if it's biofilm. There's something called oxylipin tinhome that in the research environment has been tested and shown to be elevated in breast implant illness patients, but you can't commercially test for it. The thing that tells me honestly whether or not someone who's gonna they're suffering, right? So you got somebody who's really got a lot of symptoms. They've tried all the things and they finally like give us a call. And usually, either virtually or in person, I can get them to give me enough information. So they'll say, I feel bad all the time. Like my muscles hurt, my joints hurt. It's hard to walk sometimes. It's hard to get out of bed. All these things. Now, in that select group of patients, many of them have had a trial of steroids. So if they've had a trial of steroid, I'll say, "Hey, did any of these symptoms get better?" And invariably, they all will say yes. So going back to what I said earlier about removing a implant-based reconstruction and doing a natural or autologous reconstruction. So that would be like doing an organ transplant between genetically identical twins. You don't need drugs because they have the exact same immune system. Everything else after that needs a drug. So a non identical twin would need some form of immunosuppression. And then if I were to give you a kidney or you were to give me a kidney as a transplant to save our lives, I would need drugs or you would need drugs. Those would be steroids and some other immunosuppressants, cyclosporin, azathioprine, whatever that may be. Now, the first kidney transplant was done between genetically identical twins because that's the case. It's just a technical exercise to establish blood flow and hook up the ureter to drain the kidney into the bladder. Similarly, papers out of Denmark last year showed that at the tissue level, people who have capsular contractures or thickening or firmness of the scarring are having more of a organ rejection picture. So they're having increased T cell response, which is the natural thing that we see normally, but they're also having an increased B cell response, plasma cell response, and macrophage response at the tissue level. And they're measuring it with RNA. So that means the proteins are being produced that they can measure from those cell types. And that's very different. That's the first time that's ever been reported in the history of the world. But it makes perfect sense, right? I said that if you replace the implant based reconstruction with tissue that's your own, that should end it. That should stop the signaling. So this is why I advocate for capsulectomy. It's why it makes sense to me. Because if you leave capsule in that's got bacterial contamination, that's a signaler. If you leave capsule in that's got debris from the device, that's a signaler. If
Mhm.
you have a firmness, thickness, and you have this upregulation of cell types at the tissue level and you leave the capsule in, you still have the signal. So that's why when you hear people say that, like they either have explant regrets or that they still have symptoms after explant, you should ask them, did they have a complete capsulectomy? And if anybody listening asks the question of like, why do I advocate for that? Like one, just go back to what I said. All cancer patients I would treat the same way. A complete capsulectomy, because you have to send that off to make sure they don't have recurrent cancer. You have to check everything and make sure it's not infected when you take it out. Those are just basic fundamental principles. So I do the same thing for the cosmetic patients because I already showed that, and I have the largest series in the world that 29% have bacterial contamination on PCR testing. And I think the problem would be easily solved if everybody who had this showed up to the emergency room or their doctor's office with a red swollen breast. Everybody'd figure it out.
Right.
But because it's not, it's in the prodromal phase. For everybody listening, that's the phase before you get the red swollen breast. It's just, it's on a slow burn,
Right. And so, for
smoldering.
our listeners that maybe don't know all of the terminology, when we're talking about the capsule, we're not talking about the implant. We're talking about
No,
the capsule that the body forms
yeah.
around
Yeah,
the
sorry.
implant.
That's the collagen sac your body makes, so it's scar. And the misperception is that scar is impervious. It blocks everything. That is not true. Think of it like a screen door, which allows signaling between the breast tissue and anything inside, including the bacteria on the surface of the implant and the implant itself.
Okay.
So, any debris that comes off of that, your T cell receptors would look at as foreign. Any bacterial biofilm, your body would see that as foreign. And that can oxidize the oleic acid, the fatty acid in the breast, and lead to the production of oxylipin 10.
Okay. So the difference is most standard explant surgeries are just taking out the implant itself. They're not addressing the capsule. And this is what is different about what you're doing. And you're not only removing the capsule, but you're doing that fat transfer, which is actually now introducing healthy, normally functioning tissue back into that area to basically turn off the immune response in that area where the capsule was. Am I following you correctly?
Yeah, I know that there are plastic surgeons around the country who are saying that you or advocating not to remove the scar tissue capsule because they think it's dangerous, it's not necessary. And logically, those things are just flawed, right? So taking out scar tissue is not quote unquote dangerous. You're not going to injure anybody. And saying it's not important is not being familiar with the literature or understanding the basic immunology I just described.
I was going to say how the body works.
So, like, those things don't, like, I always tell patients the same things. Like, if someone says they're not comfortable as a surgeon doing something, then you should just leave.
Right.
That's fine. Just say you're not comfortable. Don't fear monger the patient. Don't scare the patient.
Right.
It's not hard to do. I've done several thousand of them. Just because you can't, don't want to, or don't feel comfortable, don't say somebody can't have something done just because you don't want to do it, or you don't know how to do it, or you don't feel comfortable. That's not fair to the patient. Like, I don't do noses anymore. So what?
Right. Doesn't mean someone doesn't want their nose done or need to have it.
Yeah,
Not
if you
need,
call my
but you know what I'm saying.
office and ask for your nose to be done, they'd tell you he doesn't do them anymore.
Right. So tell us what's different about your SHARP method. How does it support patients before and after their surgery?
I think fundamentally, in 30 years of taking care of patients, the more you can do up front to take care of the patient and get them in the right situation, the better the outcomes are. So I don't like reacting to problems. I would prefer at my old age to really just have them organized and start crossing them off the list. So I have spent a lot of time with genetics and have a really good understanding of the genetic archetype of the patient who has the most symptoms. And I have some basic assumptions like you have a poor vitamin D pathway, BDR, GPX, which are just genes. You have a poor methylation pathway. Everybody's heard about MTHFR, although I had a patient recently tell me they didn't know what that was. It's hard to believe. The glucuronidation pathway is one that I find pretty fascinating because that one handles a lot of burden, I think, from a liver standpoint, and it's probably been underappreciated. Uh, And then the final one is the SOD2 pathway or the antioxidant pathway that handles our oxidative stress burden. So our cells work really hard, build up a lot of free radicals, and then it has to be detoxified. Think of it like you're working out hard and you get really, really sore. Your body's got to recover. So those are fundamentally flawed in my patients. Plus, many of them have really poor estrogen metabolism, high levels of estrogen. So if you have all five of those going on, you are going to be the most likely to have this problem develop. But honestly, if you just took the implants out of the equation, that would probably be a pretty good combination of problems to give just any chronic illness picture.
So what is your method? I mean,
Yeah.
obviously you're prepping them before and
So we look
but
at
but what are
genetics,
you doing?
the toxicity burden. Like most of the patients will have toxins like mycotoxins or organophosphates or heavy metals or something. Now, I don't try to solve heavy metal burden up front because I don't know what, if any, is coming from the implant. I try to get a mycotoxin burden diminished. So we have an antifungal protocol for that. And I recommend they do hyperbaric before that as well, before they get here. We look at a gut test to see who, if we can, has a parasite or another overgrowth and try to help them. Try to get their diet organized with a sensitivity test so we can not put them on a elimination diet, which seems very crude. but actually just have them eat according to what currently makes the most sense for them and then check their hormones. I have a lot of people with a lot of testosterone suppression, and we try to help them with some basic guidelines before that. So that's the prep. It can take 2 weeks, 6 months, depending on what their logistics are to get here. And then through those protocols and preparations, they show up the day before. We see everybody, go through everything. And then I have a ERAS protocol the night before, which is a couple medications to diminish nerve pain, nausea, inflammation. And then the next day, our anesthesia providers do ultrasound guided nerve blocks with local anesthesia to provide anesthesia before they ever get back to the operating room. And then we provide more when we do it. You mentioned doing simultaneous fat transfer, which I feel should be the way forward for this in the country and around the world. So, although I don't want to write another book, I feel like that's going to have to get written at some point. If you take fat from other places after preparation of the patient properly and looking at their DEXA scan, knowing their BMI, counseling them on diet, sleep, nutrition, all the things, you set them up to have a less, I would say, emotional or psychological change from the appearance because everybody's worried about the appearance. That's why you got them typically. And obviously, we know that. We're trying to do our best all the time, but usually the toughest cases are the low BMI patients. So, low body fat patient, big implant, never a good combo. So, I always try to help wherever I can to prepare them, get them ready. And if I can do a simultaneous, I feel like that at least gives them the best kind of one time treat. Anything after that, if they want more volume, certainly if they have enough fat over time, they can do another fat transfer because that's natural and you can add to it. If someone had skin that needed to be revised over time, most of those things are just done under local in the office. So it's not the easiest group of things to get done for patients, but still find it very challenging. I try to help this group of patients. I think there's a lot of it hasn't gotten the attention it deserves, and certainly has gotten me a lot of grief for providing attention for it.
I'm sure it has. Anything controversial, anything that, isn't relying on drugs and, things like that tend to get scrutinized these days. But
Well, oddly enough, the implant companies, the two major implant companies, are owned by pharma companies. Just so you're super clear.
doesn't surprise me at all.
Uh,
So I want to talk about what factors determine whether someone would have a successful explant surgery versus those who continue to struggle. But
mhm.
before you answer that question, are there actual toxins that are being leached out of these actual implants that are contributing to the overall toxic burden with a patient? Are you suffering from Lyme disease or another complex chronic illness and aren't sure who to trust when it comes to herbal supplements? Hi, I'm Dr. Mariah Hinchy, founder of Lymecore Botanicals. As a naturopathic physician specializing in complex chronic infection driven illnesses like Lyme disease, I needed herbal medicine I could truly trust. That's why I formulated Lymecore Botanicals, where our herbal tinctures are handcrafted in small batches right here in Connecticut. We use the whole herb, never isolates, to preserve the full spectrum of medicinal compounds. Every single step from sourcing to extraction is done with precision to ensure maximum purity, potency, and consistency. These are the same herbal formulas I use to heal myself and have used for years to help my patients and family members heal too. And now I'm making them available to practitioners and patients everywhere. Lymecore Botanicals, herbal medicine you can trust from a doctor who lives this work. Learn more at Lymecore Botanicals. That's LYMECORE.com.
Yeah, I mean, I got in a lot of trouble for this on a show I did with a patient of mine, Lauren Bostic. So Lauren Bostic's my patient, and she had a very aggressive sauna regimen. She had a dry sauna that got to over 200 degrees Fahrenheit, and she would do that for 60 to 90 minutes at a time. And so she would come to me and say, "Hey, I think I was just melting my implants. I felt terrible after those sessions." And on her podcast, we said, "Yeah." you're probably just melting your implants. Well, that got me accused of an ethics violation. And so the proper scientific terminology is leaching. So think of a plastic water bottle. You overheat the water bottle, the phthalates come out of the plastic, which is a plasticizer to make it firm. Gets in the water, you drink the water, disrupts your endocrine system. So in this setting, you're getting overheated. The shell components, the heavy metals, tin, cadmium, platinum, aluminum, all the things come out into your system. And then your body tries to deal with them, right? Your liver's trying to handle them. You're trying to excrete them in your urine. So, without any provocative challenge, I think we did her toxicity test and she had the most heavy metals of any human I've ever taken care of.
Wow. I never would have imagined that there's heavy metals. And I mean, maybe I've never really looked into the
Mhm.
topic. And I know
Yeah.
this might sound very naive, but like I never, ever would have imagined that there's heavy metals in breast implant material.
Yeah. Tin in particular is a bad actor for your brain. So, if you get high levels of tin, you can have a lot of neurologic uh,
Yeah. Well, like an
dysfunction.
aluminum being like an adjuvant, right? That
Yeah.
stimulates the immune system and whatnot. Like, I guess just hearing that and understanding that
Yeah.
connection to me explains a lot.
Yeah, so I mean, I got in a shit ton of trouble for that, which is nice. I mean, but people stop sauna, and then now, when we want to rise out of people, I just say something about it. Usually gets a few comments, but nonetheless, like I would have been able to answer the question had I never said that on her show, because more and more people would have just kept doing it and coming in. But because
Right.
of that show and her influence, a bunch of people just stopped in their tracks. And that was probably better for them. So I think as a public service announcement, if you feel bad after sauna and you have breast implants, then just don't sauna. Just be mindful of that as a potential thing that's happening. And if you want some guidance, I can't operate on everybody around the country and around the world. So we have a program that's ran to help patients with implants better understand it. So we have testing that can be looked at. I mean, most of these things are not that cryptic. It's just like trying to answer the question, but you have to ask the question like, is this really a problem if I sauna? And people ask me all the time, like, can I sauna or not sauna? I'm like, well, do you feel bad after you sauna? And they're like, "No, I feel great." Then that's fine. Then just
Right,
do your
right.
thing.
Listen to your body.
Yeah, if you feel like trash, that's not good. Like
Right,
that's you should look into that. That's not the goal, right? That is called a Herxenheimer reaction. She was basically giving herself a Herxenheimer reaction every time she went in the sauna because she
right,
exceeded her level of detox capability and she would just not feel well. I don't think it's that complex.
right, right,
If you just listen, I mean, uh, it sounds logical if you just think about it.
right. So, for our listeners that have Lyme, mold illness, or
Yeah.
another complex chronic condition, does this change your approach or like do you do anything differently knowing that those infections are there? Do you want someone to have as best to their ability have shrunk those infections, got the immune systems as much back into normal functioning as possible before you do the surgery? Or is it like no, part of the healing journey is getting this piece, the explant piece and calming that down is super important, so it's something that you would actually maybe do in the beginning. Like, how
So
do
what
you
I've
broach that?
Yeah, I've had it done, I think most successfully by patients who've gotten their Lyme treated and if you can control it.
Yeah,
And then if we've identified a mycotoxin burden, then I feel really strongly that has to be treated up front
yeah,
with how we discussed an antifungal, a binder, a medical grade binder. And then I will tell you, and to me, it makes a big difference. And the patients I've taken care of personally is hyperbaric up front. And then certainly when I do a fat transfer, I encourage everybody to do hyperbaric for at least a month after. I have it in my office. I have a hyperbaric chamber, a human regenerator, Flowpresso from New Zealand, and we do that with Nano V, and we have a big red light. And so, like, you're going to get everything at our place, but once you go home, just because of the sheer size of this country, it's very challenging to get everything. And if you're in a small area, of course, it can be harder. But many of the wellness places now are getting like at least a horizontal 1.4 atmosphere chamber so you can do it. I have a
Yeah.
vertical one because I do chest surgery and breast surgery, and I don't want anybody pushing and getting in and out in a way that could disrupt something we took care of. But I think all those things are important. I still, I want people to be as healthy and feeling as good as possible beforehand because I am not Harry Potter. I'm not going to magically make anybody better with surgery. I'm going to cause the biggest cortisol burst you've ever had in your life.
Right. So, on that note, what kind of outcomes do you see in your patients after explant surgery and after they've gone through your method?
Yeah, I think the most complex thing is the gut. If you eliminate the gut, I feel like we're high in the 80s and 90s of solving problems. But these gut problems, and in particular these parasite problems, they just linger and they're not easy to take care of. And they make patients really unwell for long periods of time. I just saw this patient who's 9 months out. Everything we did from a, a breast perspective is fine, but still has acne, still is dealing with constipation, still has, energy level issues, intermittent problems with um, irritation of the urinary tract. Like these all to me are rooted in the fact that she's got an untreated parasitic problem. And we're going to, be more aggressive with that. A lot of people want to just use homeopathy, and we support that and try to do that with everybody. But this is like persistent now, and you know how hard it is on a gut test to show a parasite. So if you have one, which we have one for this person now, we're going to treat it and see if we can just help them start to feel better. I just ask the same questions all the time to everybody, like post op. At a month and 3 months, I'm like, "Are you feeling better?" Yeah, overwhelmingly, it's yes, with the exception of these gut issues that linger. And if you ask all of my practitioners that work for me, because we have 3 full-time detox practitioners, they're all going to say the gut is the hardest thing to solve.
Yeah.
So it's not like, did I get the chest or breast part solved, or did I, get the fat in the right spots and all the things? Like that's not the thing that causes the problems long term. It's always gut things.
Right. It's very hard to heal or to take any therapy or do anything if your gut is not functioning properly. And even with everything that I do to help people heal from Lyme and other complex chronic illness, it's all in the gut. You can't detox if your gut isn't functioning properly. So
And we
it's
should
funny, we do
qualify
a
that.
lot of very similar tests and
Yeah.
treatment modalities.
And we should always qualify this. I don't do more surgery on people with gut trouble. In fact, I
Yeah.
pause, I delay. If you have a bad tox profile, invariably that's leading to liver and gut dysfunction. So you're going to get delayed on what you can do. Anyway, I'll have those patients ask for more elaborate procedures, but I won't do that. I'll just say, hey, we can do this explant for you or explant lift, pretty much very similar recoveries. And then all that hard work with the gut and the liver and everything has to be done. And it may take 6 months, it may take a year. I don't know. Everybody's very different. And depending on what they got into in their life, I mean, it's going to take a while to unravel.
So, what would you say to patients that suspect their implants are making them sick, but they're dismissed when they bring it up to their physicians? What
Yeah.
sort of resources do you have that could help them, or what would you say to them?
Yeah. I feel like, you used to be able to type in breast implants and I would be the top of the feed for YouTube. And then I was taken off last summer because they changed their health policy. They stripped my US licensed doctor YouTube badge and then they took me out of feed. So I think I used to get on some videos 6 million views, but now I don't get any, basically. So, but you can go to drrobertwhitfield.com, which is my main website. And I think we put together the best set of resources for women looking for answers about breast implant illness as a general condition, how to diagnose, how to treat, how to recover, knowing that this is not some easy diagnosis, right? I don't sit in an interview and try to diagnose anybody. I try to listen to like historically, what did you get into? Where'd you travel? What are you experiencing? What have you done that helps? Where are you in the moment? And then, of course, we have resources for the worst possible things, which are breast implant associated cancers. I've given testimony to the FDA hearings about breast implant illness and breast implant associated cancers. That's on there. We have a private community now. So if people just want to ask me questions, they can join it for free and they can ask their questions. Nobody's going to censor them and nobody's going to censor me in the community.
Can you share what that community is and how patients can
Oh, yeah,
find
yeah,
it
yeah.
or people can find it?
Yeah, when you go to the website, drrobertwhitfield.com, it's called Join the Circle, drrobcircle.com. And so, we created that just people could ask questions and not be worried about, like people don't like me on Facebook or Google or I don't care. It's fine.
Yeah.
It's all good.
So do you have like a monthly event or a quarterly event where people can come on and do live Q&As, or how does your circle work?
Yeah. So currently we go live Tuesdays and Thursdays at 7 p.m. Central and Wednesdays at 2 p.m. Central.
Great. So 3 times a week.
Yeah.
So, if you're listening and you have questions about breast implant illness, you can come on to Dr. Rob's Circle 3 different times a week and you can get your questions answered and see if this might be contributing to your complex chronic illness.
Yeah. And you can always go and check out any of the videos. I think the most important thing, Dr. Hinchy, is patient stories. We have a bunch of patient stories up that you can listen to them. I mean, the patients basically, they're the reason why we do what we do, obviously, but their explanations of what they experienced are the most important things, right? Everybody's going to be very different. And I always get asked, have I ever heard of this symptom or that symptom? And the short answer is no, but given enough time, I probably will have. And when I say that, I probably have heard of most things you could say over this several thousand cases I've done, but they really answer the questions and tell you the story. Like I will get everybody prepared and do the surgery properly and help them recover. I have a great team. None of us can do anything without our teams. Mine is exceptional in Austin, Texas. And I have patients who've had the surgery on our team. So you're not just talking to people who work for us. They've had the surgery and done the program. So they're fully invested in helping everybody get from this point to heal.
That's great. Is there anything else that you'd like to share with our listeners that you think it's important that I may have missed asking you?
No, but I will say that people ask me what they can do now. So the things you can start doing now are very, very simple and fundamental is work on your sleep. The thing I
Mm.
prioritize over everything else is sleep. You only recover when you sleep. So I'm very much an advocate for sleep. And women are underdiagnosed with sleep apnea. So if you ever wake up gasping or you wake up super tired or you have brain fog and all this stuff, it would be worthwhile. And I use a company called ResMed. I don't get any money from them, but you can order their test online and get it sent to you and get tested because women have this higher incidence of Alzheimer's. And the reason I bring it up is I've done surgery for almost 30 years now. And fat transfer is really since '04. Now, I know how to move fat from one area of the body to the next and do all the things. What I can't do is take you home, make you eat right, make you sleep right, and take care of yourself. If you don't sleep enough, quality depth, and have enough oxygen, your brain can only last 4 minutes without oxygen. That means when you're asleep, if you have sleep apnea, every single resource in your body is going to be sacrificed for your brain, every area, I mean. So if I put fat in a new position and it's got to heal, or I operate on you in any position it has to heal, your healing is going to be significantly delayed by one, not enough rest or not enough oxygen during that period of rest, not enough nutrition, so not enough protein. So we're always like 100 to 150 grams of protein a day is kind of normal for us in the perioperative period. And then healthy fats, of course, not drinking too much fluid before you go to bed, and then getting off your screens and all the nonsense before you go to bed, right? So you only recover when you're asleep. That's the take home. Like you can start doing actionable things right now. Investigate the products and the things you put on your skin and make sure the quality of the things you put in your body, the fluid, the food, and the air are highest you can make.
100%. This is what I tell my patients all the time as well. So, thank you for being with us.
Absolutely. Thanks for having me on.
Wonderful. Oh, and you have a podcast as well, correct?
Yeah, we just call it the Dr. Robert Whitfield Show now.
Okay. So you're on all of the major
Yeah,
podcasting platforms.
yeah,
So they also can find you there.
yeah.
Wonderful. Okay. Well, thank you so much for joining us.
Thanks for having me.
Absolutely. And to all of our listeners at home, thank you for joining us for another episode. We'll see you next time.
If this episode gave you an answer, brought you new insight, or made you think differently, subscribe to the Lyme Bites podcast and share with someone who's ready to take control of their healing journey. And if you can, please leave a review. It helps others to find the show. Thanks for listening, and we'll see you next time.